It is my pleasure to introduce our speaker for today's program, Dr. Sammy Ho. Dr. Ho is currently employed as the Director of Advanced Endoscopy for Montefiore Medical Center. Today, he will be speaking about current and future indications for endoscopic ultrasound. Dr. Ho, thank you for giving this education program. I'll turn it over to you now.
Good afternoon. I want to welcome everybody for joining me at this webinar. I also want to thank Pentex for organizing this program. What I want to do today is to go over some of the current and future indications of endoscopic ultrasound. So when do I do EUS? In my practice, the most common indication is to evaluate patients with pancreatic solid and cystic lesions, followed by the evaluation of patients with chronic abdominal pain and pancreatitis of unknown etiology. For these patients, I'm mostly looking for gallstones, common bile duct stones, and chronic pancreatitis. We often do EUS to evaluate patients who were found to have submucosal lesions on prior endoscopy. We do EUS to stage esophageal cancer, biliary cancer, rectal cancer, and lung cancer. What makes EUS an ideal modality for cancer staging is its ability to really differentiate the different wall layers. Here, for example, is a EUS examination of the stomach. You can see that all 5 wall layers are clearly defined. Besides cancer staging, knowing what wall layer a lesion is arising from does give you some idea as to the etiology of the lesion. Here, for example, you have a hypoechoic or dark mass arising from the muscle layer, consistent with a leiomyoma or a GIST. Another picture of an example of an EUS examination in the esophagus. You can see that all 5 layers are clearly seen. For cancer staging, on the left, you can see that there is a mass in the mid-esophagus. On the right, you can see that the mass is invading into the muscularis propria layer, but not through it. So this would be an example of a T2 lesion. As opposed to this lesion, you can see that it's bleeding already. And on the right, you can see that the mass is eroding through the muscle layer, and in fact, is eroding into the descending aorta. So this is a T4 esophageal cancer. EUS is also very good to detect lymph nodes in the mediastinum. Here you can see at about 9 o'clock there is a 6 to 8 millimeter lymph node. On the left is an example of a pancreatic mass in the head of the pancreas that is invading the portal vein, SMA, and SMV. On the right, you see that there's a needle going through this mass to obtain a biopsy. EUS is also very good to evaluate liver lesions to document metastatic disease. Here is an example of a 1 centimeter hypoechoic metastatic lesion in the left lobe of the liver. You see that 25 gauge needle is going through it to obtain a biopsy. If this comes back positive, of course, the patient has stage 4 disease and the management is quite different. Another common indication for doing EUS is to evaluate patients with pancreatic cystic lesions. Differentials can include pseudocyst and cystic neoplasms, which can consist of Mucinous Cystadenoma, Serous Cystadenoma, IPMN. You can also have cystic degeneration from solid pancreatic lesions, and simple cysts. Of course, knowing what type of cyst that you're dealing with makes a big difference in terms of the management. On the left is an example of a CAT scan showing a large pseudocyst. On the right, you see that on endoscopy, you can see some extrinsic compression into the duodenum. This is an example of a pseudocyst on the left and a needle going through the pseudocyst for fluid aspiration. On the left is an example of what is described as a microcystic lesion, meaning just that there are different small compartments within the cyst. And on the right is a needle going through this lesion for fluid aspiration. This is a typical appearance of a Serous Cystadenoma, which, as we all know, is benign. As opposed to this lesion, an MCN, or Mucinous Cystadenoma, this lesion, on the other hand, is pre-malignant. More so in IPMN, there is a strong potential for neoplastic transformation, especially in patients with a marrow nodule that you see on the left here, and a dilated pancreatic duct, as you see on the right. For those of us who do ERCP, sometimes we see this at the ampulla, actual mucin coming out of the ampullary orifice. And on the right, you see a pancreatogram with numerous filling defects. These are not stones. These are actually mucin. When we do fluid aspiration, we usually send the fluid out for chemistry studies, CEA and amylase. For Serous Cystadenoma, the CEA level is low and the amylase level is low. For Mucinous Cystadenoma, the CEA level is high and the amylase is low. For IPMN, especially the ones involving the main duct, the CEA level is high and the amylase level is high. For Pseudocyst, the CEA level is low and the amylase level is high. So as you can see here, using this table, by aspirating the fluid and sending it out for CEA and amylase testing, it gives you a pretty good idea as to what type of cystic lesions you are dealing with. Because the fact that EUS gives you a great access into the posterior mediastinum, it can be used very frequently for lung cancer staging. We also get a great visualization of the left adrenal gland, which sometimes can be the site of metastatic disease. So examining it during a lung cancer staging EUS is very important. This is an example of a lung cancer staging EUS examination. You see that, as I have mentioned, the left adrenal gland should be examined first. It has a little seagull appearance. This is the left atrium, the pumping structure. And between the left atrium and the pulmonary artery is the subcarinal region. You see there's a big lymph node here, about 2-3 centimeters or so. You can see that there's a 25 gauge needle going through this lymph node to obtain a tissue sampling. And just know that this is beyond a diagnostic test. It's even more so a staging procedure, because in the patient that has subcarinal lymph node, they already have stage 3A disease, making them not resectable, at least not immediately. There are a few common therapeutic indications for EUS: celiac plexus block and neurolysis to control pain in patients with chronic pancreatitis and pancreatic cancer, and transmural drainage of pancreatic pseudocyst. Transmural drainage of pseudocyst is something that I do quite often in my practice. It is a creation of a fistula between the pseudocyst and the lumen of the stomach or duodenum. EUS can be helpful in selecting the most favorable puncture site, for example, avoiding underlying blood vessels. On the left is a large pseudocyst that you see on CAT scan. On the left is a echoendoscope right next to the cyst that's made the puncture already, and you see a wire that's advanced and outlining the border of the cyst. On the left, you see a dilating balloon making a fistula between the stomach and the cyst. And on the right, you see the result of the procedure. You have two double pigtail stents going from the lumen of the stomach to the pseudocyst. One pigtail in the cyst, one pigtail in the stomach to prevent migration. Here you can see clearly that there are two pigtails going to the pseudocyst. Now sometimes we can even use fully covered metal stents to drain these pseudocysts. Here is an example of an extrinsic compression of a pseudocyst into the stomach. Inside this cystic lesion, you see that it's not just all black. There's a lot of white stuff in it. These are all necrotic debris. So you know that this cyst may be more may pose a little bit more challenge in terms of your ability to drain it because of this debris. Here we made a track again, and then a fully covered metal stent was placed, making a connection between the stomach and the pseudocyst. We can drain collections in other parts of the body using the same technique. This is a peri-rectal abscess in a patient that had a perforated appendicitis. You see that a big collection that's right next to the rectum. You see that on EUS, you see this peri-rectal abscess. We made a fistula between the rectum and the peri-rectal abscess, and a stent was placed. And you can see on CAT scan, the abscess is almost gone, and you see that the stent is going within the small abscess and the rectum. So it's a novel treatment of patients with peri-rectal abscess. In terms of the technique, is similar, except, you know, as opposed to working in the stomach to drain a pseudocyst from the pancreas, we are working in the rectum to drain a peri-rectal abscess. But the technique is very similar. This lumen-apposing metal stent came out probably 2 years ago, and the design of this stent is really ideal to drain pancreatic pseudocysts or performing therapeutic procedures such as necrosectomy. Because it does have a lumen of 1.5 centimeter, it allows you to drive a scope through this stent to do things like something like a necrosectomy. Just want to show you a video of a young patient who presented with the alcoholic necrotizing pancreatitis that evolved into an area of walled-off necrosis. Here you can see an area of walled-off necrosis involving the pancreatic body and tail. Many necrotic materials within the cystic lesion. A needle now is punctured into this necrotic cavity, and to create a fistula, a 4 millimeter balloon is used. You see it from the going from the stomach into the cavity. A stent is then deployed over the guide wire. You see that the flange that is within the cyst is deployed first. You see this V shape here. Then you pull the stent back to have a good apposition to the stomach. Here you see that the proximal flange is deployed. Of course, a lot of necrotic junk is coming out of the stent. To optimize drainage, sometimes what we do is after stent deployment, we put in a CRE balloon to dilate the stent itself to optimize drainage. You can see here, after the balloon is deflated, even more necrotic debris came out of this necrotic cavity. Now, we don't have to finish the entire necrosectomy all at once. You know, once the stent is in, there is access to this cavity that you see here. We can bring the patient back every 2-3 days for debridement until the cavity is clean. I think this patient might have come back 2 or 3 times over a 10-day period. And once the cavity is resolved or cleaned out, you can take out the stent and the hole closes up right away, and there's no need to close up the opening with any suturing device or anything like that. So this patient did extremely well. The necrotic cavity resolved and has been doing well during our follow-up. The removing of this debris can be a prolonged process. We can use forceps, we can use snares, we can use baskets. That's not really an ideal accessory for it, but we just try to do this under direct visualization. There is the splenic artery is in that region, usually in the area of a pseudocyst, so you want to be careful. Here on CAT scan you can see this dumbbell shape. of the cyst. You go in here, you can see 2 weeks later, it looks a lot better. This is all healthy pancreatic tissue. So definitely less junk in it. And at this time, we decided that it was time to remove the stent. And the stent can be removed using a forceps, quite easy. You can see here the stent is grabbed with a forceps, and then we'll just pull. We'll just pull the stent out. It doesn't take more than a few seconds. And like I said, never a need to close the defect with any suturing device or clips, and it's quite easy to do. Another example of the use of this stent is a patient with a peri-rectal abscess. Here you can see on a sigmoidoscopy there is a bulge that is coming into the rectum, and almost like the pseudocyst compressing into the stomach, but except now you're in the rectum. And okay, and a 19-gauge needle is punctured into this peri-rectal abscess, and a 4-millimeter balloon is used to create a fistula between the rectum and the abscess cavity. You can see that a lot of junk is coming out of the abscess, and the stent, just much like the last case, is deployed within the cavity, and then we pull it back to create a good apposition to the rectal wall. After this, we deploy the proximal flange into the rectum. And you can see here after the deployment, of course, a lot of necrotic materials emerged from this abscess cavity. This patient also did well. It's a younger patient. And in 2 weeks, we were able to remove the stent, and a interval CAT scan showed that there was a complete resolution of this peri-rectal abscess. So I'll just show this video to demonstrate the fact that this stent can also be used for draining other collections in other parts of the body, like a peri-rectal abscess. Here you can see a lot of necrotic materials are emerging from the abscess cavity. You can go in a little bit just to see inside, but of course, with this case, there's no need to do any debridement because everything was draining so well. But I just wanted to look inside to see this abscess cavity. It's not something that you see every day. This is a case that I did recently. It's not commonly a very large 6-centimeter liver abscess in the left lobe of the liver. After consulting with IR, they didn't think that it was an optimal location for them to do a percutaneous drainage. So they asked me to do possibly EUS-guided drainage, which we did. And you can see on the right, the same lumen-apposing metal stent was placed into the left lobe of the liver to drain this liver abscess. The procedure went well, and the patient was able to have the stent removed in 2 weeks after complete resolution of the liver abscess. Just want to show. We also use EUS to drain the gallbladder. As we all know, the gallbladder can be drained in a couple of ways, endoscopically. Here you can see the first way, probably the most common way, is transpapillary drainage via ERCP. A long pigtail stent can be placed through the ampulla into the gallbladder. More commonly these days, transmural drainage is done, as you can see here, going from either the stomach or the duodenum into the gallbladder. Numerous studies have shown that this can be safely done in patients who are not surgical candidates. I want to show you an example of a patient who was elderly patient, 94-year-old with acute cholecystitis, fever, chills. The patient was found to be not a good candidate for surgery because of her age. So we decided to proceed with endoscopic drainage. Here on the left, you see that initially the gallbladder creates a external compression into the stomach. On EUS, you see the gallbladder here with a big stone in the middle, and then a similar stent was placed to create a fistula between the stomach and the gallbladder. And here you can see, finally, you see that the lumen-apposing stent going from the stomach into the gallbladder. The patient has also did well. As you can see here, because of the age of the patient, this stent, unlike the previous ones, was not going to be removed. This was going to be staying inside of her for the rest of her life. Just want to spend a few more minutes going over some of the emerging indications. We went over some of the current indications the last half hour or so. I want to go over EUS-guided biliary access, EUS-guided fiducial placement, EUS-fine needle injection or FNI for tumor ablation, and finally EUS-fine needle biopsy. Now, we're all very good at doing ERCPs, but sometimes getting access in the bowel duct is not a possibility for numerous reasons: prior surgery, periambulatory diverticulum, tumor infiltration. For these patients, options include percutaneous drainage like a PTC or surgical drainage. But in my practice, when an ERCP fails, we often rely on EUS to help you get into the bowel duct. Here is a picture demonstrating the fact that by having the EUS scope in various parts of the stomach and duodenum, the left lobe of the liver can be accessed along with the main bowel duct from the duodenal bulb. What I want to describe to you is something called EUS-guided rendezvous ERCP, which is a way for us to use EUS to gain access into the bowel duct. So first, by having EUS scope in the stomach, we can have great access into the left lobe of the liver, as I described. A 19-gauge needle can be used to puncture into this left-sided system, inject contrast to confirm that you're in the biliary tree, pass the wire from the stomach through the liver, through the bowel duct, and coming out of the ampulla into the duodenum. Withdraw the EUS scope, go down with the ERCP scope, and now you have a wire coming out of the ampulla. You can grab the wire, pull it through the channel, and now you have access into the bowel duct. There are two different approaches, intrahepatic and extrahepatic approach. An intrahepatic approach was the one that I just described. You are injecting contrast into the liver from the stomach. The extrahepatic approach is the one that you want to inject contrast through the duodenal bulb into the main bowel duct. But the concept is the same. You want a wire to coming out of the ampulla so that you can use a snare or a forceps to grab the wire, pull it through the channel of the ERCP scope, thus creating access to the bowel duct. Well, what if the wire cannot be traversed through the ampulla? Then a rendezvous approach is not possible. Then one might consider placing a stent directly via EUS. First description is a hepatical gastrostomy. As I said, by having EUS scope in the stomach, we can have great access into the left lobe of the liver. Here you can see that. We make a puncture, inject contrast, dilate the tract, and place a stent. So this is what is a hepatical gastrostomy. This stent is going from the stomach to the left lobe of the liver. What's more commonly done, choledochal duodenostomy. Here, the bowel duct is punctured from the duodenal bulb via EUS. Inject contrast to confirm that you are indeed in the bowel duct. Dilate the tract and place a stent. Here now, the stent is going from the duodenal bulb into the main bowel duct. So a way for you to drain the main bowel duct without going through the ampulla. Example of a case that I had before, I was asked to do an ERCP on this patient. You can see the ampullary orifice is difficult to identify because of tumor infiltration. I then converted it to an EUS, injected the bile duct, injected contrast, confirmed I'm in the bile duct, place a stent, a fully covered metal stent. So now this stent is going from the duodenal bulb into the main bile duct. Similar example, bile duct, seen on EUS, 19-gauge needle, puncture, inject contrast, dilate, and now a lumen-apposing metal stent was placed from the duodenal bulb into the main bile duct. This is an example of an ERCP that I try to do in a patient with pancreatic cancer, but because of tumor infiltration, the scope could not be passed into the second part of duodenum. Then, of course, the ERCP is not possible. Here, I converted into a choledochal duodenostomy. A 19-gauge needle is punctured into the bile duct, injected contrast. The tract is dilated, and a lumen-apposing metal stent was placed going from the duodenal bulb into the main bile duct. Here you can see that the flange, I've seen this video, I'll show you a similar video a few times already during this lecture. You see this flange that's opened up into the main bile duct. See that? It opens up as a V, and then you pull this stent back to create a good apposition against the luminal wall. Then the proximal flange is deployed, creating this large opening connecting the main bile duct to the duodenal bulb. Of course, with this patient, the issue was that we were not able to traverse the scope to the ampullary orifice. So after this is done, you can place a duodenal stent in the same setting. So pretty much the patient had a double bypass in less than 20 minutes. And this is for palliation. These stents are not meant to be removed. So I want to move on to talk about fiducial placement, which is beneficial in patients who are undergoing stereotactic radiosurgery. The idea is that by placing these fiducial in the lesion, it allows the radiation oncologist to give a larger amount of radiation to a smaller area, thus reducing exposure to surrounding tissues. Usually we place 3, 4 to 5 fiducials inside a single lesion to help the radiologist to locate a lesion. On the left is an example of a fiducial placed under EUS guidance. You see this bright area here within a pancreatic mass. On the right, you can see that 3 fiducials are being placed inside a pancreatic lesion under fluoroscopic guidance. So initially, when you start doing this, you can use both, just to confirm that you can use both, and this EUS guidance and fluoroscopic guidance, just to confirm that you are in the right area. There have been numerous studies showing that this EUS-guided fiducial placement technique is feasible and safe. EUS-guided anti-tumor therapy is probably one of the more exciting areas of EUS. And these days, we can think of, as opposed to using a needle going to a lesion for a biopsy, why not use the same needle to inject anti-tumor treatment into a cancer? The most commonly studied agent has been the TNF-furay, and it has shown good promise. There are other ablation techniques that we are currently using, mostly on animal models. The use of RFA, cryotherapy, and PTT, pretty much using the FNA needle as a platform for you to deploy these ablation techniques to treat underlying neoplasm, such as a pancreatic cancer. We're not quite there yet. I think we're still a few years away, but this is definitely a very exciting area of the future of EUS. Another hot topic these days is how do we get more samples per EUS biopsy, going from what is known as cytology to histology. On the right here is a appearance of a core needle. It's got a double barrel appearance. It allows you basically to slice the tissue into smaller pieces as an attempt to give you more tissue per biopsy. This is what you want to see, a real core. Here, I just want to show you the red is not the core. The red is actually blood, but it's the white film over the red is the core. Here you can see that the white film over the red is the core. The red is the blood. So why do we have to do this? Well, by obtaining more tissue when you do a biopsy, it allows you to do more studies as opposed to just telling a patient whether they have cancer or not. It allows you to do possible molecular and genetic studies and be able to tailor each tumor to a particular chemotherapeutic regimen. So in summary, I just want to go over some of the things that we spoke about today. We spoke about some of the common EUS indications. We went over staging for esophageal cancer and lung cancer. To evaluate patients with pancreatic solid and cystic lesions. We spent a lot of time showing you videos of pseudocyst drainage and using the same technique to drain peri-rectal abscess, liver abscess, and the gallbladder. We talked about the EUS-guided biliary access when ERCP is not possible for whatever reason. We talked about EUS-guided fiducial placement in patients who are undergoing stereotactic radiosurgery to allow us to better localize the lesion and minimize radiation exposure to surrounding tissues. We talked about fine needle injection, FNI, for tumor ablation as opposed to FNA that we have been doing over the years. And we talked about using a core needle to optimize your biopsy specimen, going from EUS-FNA aspiration to EUS-FNB biopsy. I want to thank you for your attention, and now I will go to our moderator.
Absolutely. Thank you so much for a wonderful presentation. We do have a few questions coming in. I'll read to you the first one that came in. Dr. Ho, regarding the use of the Lumen pancreatic pseudocyst, how long should we have the stent in?
That's a good question. I think this issue is evolving in that in the older days when we were using the double pigtail stents, we were always taught to leave the stents in for 6 to 8 weeks. But I think that's a little too long these days because this newer lumen-apposing stent can drain the cavity so much better. I don't think it's necessary for you to leave the stent in for so long. So in my practice, for a simple pseudocyst, I oftentimes leave the stent in for around 2 weeks, do an interval imaging to confirm that the collection is gone, and most of the time within 2 weeks it's gone. Then there's really no need for you to have the stent in for another 4 weeks for no reason. So after that, I oftentimes just remove the stent. So to answer your question, much shorter these days, from pretty much from 6 to 8 weeks to 2 weeks.
And actually the second part of that question is, should we consider stent placement and necrosectomy in the same setting?
When I first started doing this, I was doing the necrosectomy right after I deployed a stent. But over the last couple of years, I have stepped away from that for a couple of reasons. One, when a stent is freshly deployed, there may be a risk of dislocating the stent as you are doing the necrosectomy, moving the endoscope in and out of a freshly placed stent. It has not happened to me before, but I would imagine that could be a risk. And the second reason why I don't do this anymore is because even though there's a large necrotic cavity, because the stent can drain these lesions so well that even though you think you may need a necrosectomy, when you do a repeat imaging in a few days or in a week, the cavity looks very, very different. And you don't really need to perform necrosectomy on these patients. And they actually do quite well with just being left alone and being drained by this new stent. So these days, I do not do the necrosectomy in the first setting, and a lot of times I find that it's not even necessary when they come back in the second setting anyway.
Dr. Ho, I have a question that came in that asks, under what circumstances do we consider using a core needle as opposed to a regular FNA needle?
This is another perfect question in that I think the regular FNA needle over the years, as we know, the diagnostic yield for something like a pancreatic cancer is quite high, over 90%. So there's not so much room to improve there. But for other lesions like lymphoma, GIST, sarcoid, I think there's much more room for improvement. And for those lesions that when we suspect that they have those diseases, I may consider using a core biopsy to optimize our yield, because we do know that the yield with the regular FNA needle is not so high. Another occasion when I would consider using a core needle is that basically, you know, this might be common sense. When a patient is coming back for a second procedure, when the first procedure was non-diagnostic, whether it was done by me or done by somebody else, I would definitely consider using a core needle so that the patient wouldn't have to come back the third time. Another reason that I could think of right now when you would consider using a core biopsy needle is that when you don't have a cytologist in your room to do your initial assessment to tell you whether you have enough tissue or not. I don't think this happens too often, because I think most of us do have the benefit of having a cytologist in the room when we do FNA. But in those circumstances when we don't, I think I would probably use a core needle just to get more bang for your buck when you do your biopsy, because no one is there to tell you whether you have enough tissues or not. So those are the circumstances where I would consider using a core biopsy as opposed to using a regular FNA needle.
Thank you so much, Dr. Ho. I'm afraid that is all the time that we have for today. On behalf of Pentex Medical, I want to thank you for sharing this valuable information. This concludes today's continuing education program, and we look forward to your participation in the upcoming webinars remaining in this series. Please remember to sign up for Patient First on pentexmedical.com. A link to register will be provided on the site. Thank you, and have a great day.